Sir, we are live now.
Yeah, thank you. Can I share my slides now?
Yes, sir.
Ranjit? On. Ranjit? Ranjit, on share slides. Wait, but
No. No.
oh.
No.
Oh, fine.
No pertama.
Oh. Is it okay?
Yes, sir. It is okay. You can start with the session.
Oh, so I will start. Good afternoon to you all. I am indeed happy to join with you in for the Med Talks arranged by IGCP of KK Agarwal Foundation. The topic I am going to discuss today with you all is syndromic management of sexually transmitted diseases or infections. I'll narrate a case study, few case studies. A 19-year-old male came to the family doctor after a sexual exposure with multiple pinhead projections over corona glandis. So the family doctor saw it and he said, it is look like warts. I'll refer you to a venereologist. So, and he will apply the medicines and it will fall off. With this, and a reference note, he referred to as a venereologist. The venereologist, on seeing it, said, this is not warts. What you have is pearly pineal papules or ectopic sebaceous glands or Fordyce glands, and 20 to 30% of the males will have this. And you need not worry about it. It is indeed beneficial rather than harmful. What you have to observe is to retract the prepuce during the bath and clean it gently. And you need not bother about it. So this boy, he had not cleaned his genitalia or glans penis by retracting the prepuce so far. But once he had a sexual exposure, he thought he will get the disease. And the next day, he retracted and saw this thing. See, no venereal disease will occur, that too, warts will occur on the next day of the exposure. The incubation period is 3 months to 6 months. And what is normal for him, he and his family doctor mistook it. I'll narrate another case study. Here, a newly married girl went to a lady doctor with 2 months of amenorrhea. Nowadays, everyone is very worried. They want to become pregnant, or more than the couple, their parents want them to get pregnant and give the grandchild at the earliest. Pregnancy was confirmed by urine gram index. As you know, it is available over the counter. They themselves can test it, or they can go to a lab and get it tested. Following this, she consulted an obstetrician, and blood tests like hemoglobin, blood group, RH, blood sugar, and VDR were done. These are the tests which are done for any antenatal case during their first visit. The VDR report came as reactive in 2 dilutions. And the obstetrician asked, well, what is your husband doing? He said he is a sales representative. Does he go outside or thing? Yeah, sometimes he goes and he will return only after 2 or 3 days. So this obstetrician said, perhaps your husband has given the disease syphilis to you and you have got it. Anyway, I'll refer you to a venereologist and he will treat you and your husband also. So the patient was referred to the venereologist, and venereologist seeing this, he did another test called TPHA, Treponema pallidum heme agglutination test. This is because VDRL, though a very sensitive test, it is not the specific test for syphilis, because the antigen used here is not from Treponema pallidum, but from bullock heart muscle to which lecithin and cholesterol are added. So biological false positive can occur in other than syphilis, that too in pregnancy, and that too when the dilution is less than 8 dilution. So always do the VDRL not as a qualitative test, but also as a quantitative test. And if the VDRL is more than 8 dilution, we can take it as due to syphilis, and otherwise we have to rule out biological false positive. The TPHA result came as negative. So if the venereologist had not done this TPHA, the poor husband would have been blamed for giving the disease, and they might have even aborted the fetus. The third one is 45-year-old male came to a family doctor with symptoms of anxiety. He complained of burning sensation over genitalia at the start of the intercourse itself. He opined that his wife has become more hot. It is like putting the wooden block into the fire, and the penis had severe burning sensation on introduction of the penis into the vagina. The doctor saw and there was nothing wrong in the genitalia, and he said, so nothing to bother, your genitalia is normal, you need not bother about it. 3 months later, patient came again with painful fissures all over his prepuce. The prepuce was sodden, that is dirty white in color, and multiple fissures, longitudinal fissures were there on the prepuce. And so the family doctor referred to a venereologist, and the venereologist seeing it asked whether the patient is diabetic. He said, no, I am not diabetic. My wounds heals well. I don't have any other symptoms of diabetes. Anyway, we will have the blood test tested, and the blood sugar random by glucometry came as 330 milligram per cent. He said this is due to diet. This is Candida albicans. The positive organism is not from your wife, but from your own itself. And whenever the sugar is more than 180, the sugar will come out through the urine. Glucose, you will have glycosuria, and this urine over the prepuce will cause the Candida albicans, which is there in your gut route from mouth to anus, will infect here, and this is being caused. And he said, I'll write one medicine, 1 tablet of fluconazole and a cream of clotrimazole. So candidal banuloparasitis may be the first presenting symptom of diabetes. Here, the fourth case, 63-year-old man went to a doctor in Tirutani with proliferative foul swelling and bleeding swelling over the entire glans penis. It was a protruding growth. The doctor did not palpate or elicit history. He referred him to Stanley Hospital as carcinoma penis, Chennai, as carcinoma penis for favor of partial amputation of the penis. After 1 month, this patient returned home and came to the doctor for follow-up. The doctor was curious how much of penis has been chopped off, and without asking any question, he examined him in privacy and saw the entire penis intact. No part of the penis had been chopped off. And he became still curious and asked the patient. He said, you referred me to surgical department. From there, they referred me to venereology department. And they took my history that I had exposure, even though my wife was dead. I had an affair with some unknown woman, and I had developed this. So they gave medicine for 15 days, and the entire they took the part of this growth and examined under microscope, and they gave me medicine for 15 days, and the entire ulcer healed completely. So this is called as venereal granuloma. When it occurs, so the penis may mimic carcinoma. We should remember that STI can occur in old people, and old people, some of them may not refrain from abstaining from sex, and they may have extramarital contact and develop sexually transmitted infections. So the time is always like a wheel. It keeps on rotating. The passions do change with time. When I did post-graduation in the late 70s and early 80s, radio diagnosis was taken up by many of the people. They took general medicine, surgery, pediatrics, ophthalmology, like that. Radio diagnosis was not one of the priorities. But after ultrasound, CT scan, and MRI, radio diagnosis has become very, very important and lucrative. And they can sit in the patient console room, and they will have a lot of assistance to take CT or MRI, and they can give the opinion. Sometimes they give the opinion from a scan center, even away from it, through this internet, and they give the report. They see the film and give the report. So the top ranker in NEET nowadays prefers radio diagnosis. Same way, many people did not join anesthesia. So we have qualified anesthetists. So the MBBS graduates were given training in anesthesia and used in anesthesia to give anesthesia during surgeries in taluk and district headquarters hospitals. But after super specialty surgeries emerged, and intensive care units with ventilators also became very common in almost all the secondary and tertiary hospitals. There was a demand for qualified anesthetists, so many people take anesthesia now. Same way, the venereology, after HIV and AIDS, and that too sildenafil in erectile dysfunction, it has become one of the favorite branches, and many people, without revealing their identity, they want to come to the venereologist and have treatment. So, so the wheel is there. Nowadays, the preference is for radio diagnosis, venereology. Dermatology is combined with venereology. So there is a huge demand for dermatovenerology. There is No other specialty has changed its name. Cardiology is always cardiology, neurology is always neurology, like that. But venereal disease, VD, which included only 5 diseases, and the term venereal is derived from the Greek Roman goddess of love, Venus. So these diseases are not due out of love. We had Valentine's Day recently, and those who love will not get this disease. Only people with lust who do not bother about the partner, place, or time, they get into problem and develop this disease. So the name was changed into sexually transmitted diseases, STD. And to say it as a disease, we should have signs and symptoms. It should manifest itself with signs and symptoms. But here, the person may be suffering from the disease, but he may not have symptoms or signs at all. So he may be a latent patient, infection patient, and he is infective also. Doesn't mean that he is not infective because he does not have signs and symptoms. Here the organisms will come out through the semen and vaginal fluid and infect the partner, sexual partner. So the name was changed to sexually transmitted infections, STI. The obstetricians, they also treat this infection, especially women patients. And so they wanted a name, not STI, but they suggested reproductive tract infection, RTI, involving the vulva, uterus, cervix, and other things, reproductive tract infection. So in 2003, the venereology and dermatology reunion occurred. We had a separate PG course in Tamil Nadu and Andhra Pradesh, and rest of the states, they had combined dermatovenerology. So the MCI wanted a uniform pattern all over India, and they merged venerology and dermatology in these 2 states. Now the venerology has become a subspecialty or super specialty. Only the time has to tell. So I'm telling you a definition. This is an infectious disease, systemic from the onset, capable of involving each and every structure in the body, characterized by florid manifestation on one hand and periods of complete latency on the other, can mimic many diseases in the field of medicine, transmissible to the offspring, transmissible to certain laboratory animals, and treatable to the point of presumptive cure. At that time, there was no, this is a definition given by Stokes for syphilis. At that time, there was no blood transfusion facility, so he has not mentioned that it is transmissible by blood also. So, syphilis forms the differential diagnosis for many of the diseases in almost in all the specialty, right from psychiatry, neurology, cardiology, obstetrics, gastroenterology, surgery, like that. Syphilis forms a differential diagnosis, and VDRL is always a test written for all patients in all specialties. Now I would like to tell about the relationship between HIV and STD. HIV is yet another STD, sexually transmitted disease. Initially they thought it will spread by blood transfusion or needle prick injury. But yes, they do spread. But nowadays we have all the blood units being screened, and we use only disposable syringes and needles. So these 2 modes of spread has become a very rarity, and only way now HIV can spread is through STD, through sex. Sex is the predominant mode of transmission, and for same risk behavior is there for HIV and STD. Either premarital contact or extramarital contact, unprotected sex without using any condom, and the thing. And STD clinics provide important access point for HIV patients. When we screen normal population, it is less than 0.25 to 1%. In any country, or any states, it is only 0.25 to 1%. But when we screen all STD patients attending the STD clinics, it is about 8 to 10%. So it is more than 10 to 20 times more common in STD patients rather than things. And because STD facilitates the acquisition and transmission of sexually transmitted. When I discuss HIV separately, I will elaborate about this point. STD trend can be a good indication of sexual behavior. Whichever countries which had sexually transmitted disease in large numbers, they had huge population suffering from HIV. Control of STD leads to control of HIV or AIDS. So in Africa, in some of the countries, they had 30 to 40% of the people having HIV. And what they did was they gave presumptive treatment for STDs to all the people, and the new cases came drastically down. Because all STDs has been treated completely, and the HIV could not enter through normal. It became just like any other population of 0.25 to 1% incident. So let us go through the spectrum of sexual injury. It is not a single disease. This is a single painless indurated ulcer with painless lymphadenopathy called chancre or primary syphilis. This is grayish white moist flat top lesions occurring over the mucocutaneous junctions. This is condyloma lata, the secondary stage in syphilis, which is most infective, teeming with Treponema pallida. This is a purulent discharge from the urethra. We have to ask the patient to retract the prepuce and squeeze the glands. And if you see purulent discharge, this is gonorrhea. If it is a mucoid discharge, it may be due to chlamydia. Here, multiple ulcers, painful ulcers are seen. This is phagedenic chancroid, which has destroyed the entire prepuce. Auto-circumcision has happened. Phagedenic chancroid. These are warts. They differ from skin wart, and I will have a separate lecture about genital warts. This is warts in a female. This is, you can see multiple vesicles. So this is herpes simplex, genital herpes. And structure to form multiple superficial ulcers, and sometimes they coalesce also. So I will have a separate lecture about herpes also. This is even though it's single ulcer, the surface is granulomatous and it bleeds on touch. So this is venereal granuloma. It can spread subcutaneously to both the inguinal regions, and they are called as granuloma inguinale. This is lymph nodes above and below the inguinal ligaments have enlarged and they are tender, and this is lymphogranuloma venereum, where there is no genital ulcer, only the lymph nodes. Pubo, we call it as pubo due to lymphogranuloma venereum. These are the various sexually transmitted. We have still more diseases, right from scabies. Anything can be sexually transmitted because the contact is more intimate and more prolonged during sex. and almost all contagious disease, they become sexually transmitted also. And the management of sexually transmitted disease, we have only few conditions which are very typical, which can be diagnosed clinically. The benefit is it's time-honored and time-tested, and it is simple and cost-effective. Need not be in STA. In other specialty also, clinical approach has got its own benefits. But the limitation is poor presentation due to prior treatment. Before coming to the patient, if the patient has taken treatment, gonorrhea can look like chlamydial infection. And sometimes there can be mixed infection. The single ulcer, Treponema pallidum and Donovan bodies have been demonstrated. So mixed infection can also occur. Next one is the etiological approach. Each sexually transmitted infection is caused by one organism. So we can demonstrate that organisms, and when we demonstrate it, benefit is we become accurate in diagnosing, and we can use a single drug to cure it. But the limitations are we need equipments and expertise and time consuming. When the patient comes today, when we take the test, do the investigation and ask the patient to come after 1 day or 2 days, patient may not turn up. So we will be missing treating him. So the third approach is called syndromic approach, where we treat as a syndrome. If it is an ulcer, we treat for all the conditions which cause ulcer. If there is a urethral discharge, we treat for all the conditions which can cause urethral discharge. But this is not unscientific. It is not polypharmacy. It is not new also. In the busy OPD, when 300 to 400 patients are seen, we put the diagnosis of any fever as PUO, any sneeze as URI, any cough as LRI, any burning micturition as UTI, any loose motion as acute diarrheal disease. So it is not a disgrace, but it is the need of the hour, especially when the HIV is spreading as a pandemic. So we have to treat sexually transmitted disease at the earliest by this syndromic. So this is the sword and this thing we have. So we have to treat the patient and protect from HIV. The benefits, it is simple. There is no misdiagnosis, no ineffective treatment, single visit sufficient, no waiting period, no social stigma. We put the diagnosis as RTA. If the ulcer is there, we put it as GUD, genital ulcer disease. Nobody will understand this is syphilis or chancroid or venereal gland. And it is cost effective. Even though we treat for 2 or 3 conditions, we are saving on the lab. Lab costs so higher than the tablets. Limitation is poor follow-up. We'll have a lot of difficulties. Overdose and wasting of drugs. Asymptomatic people escape. I told you STI. Poor correlation of STD and non-specific genital ulcer, genital conditions. So we have a flow chart. In Africa, not only the doctors, even the paramedical people, they follow this flow chart. I will narrate one. If a patient comes with genital ulcer, we have to take relevant history, whether he had unprotected sex, premarital or extramarital other than his wife, and examine the genitalia. If there is no ulcer or vesicles, we have to re-evaluate, educate on safe sex and send the patient. If the vesicles are intact, broken, history of recurrence, if it is yes, then we have to treat it as genital herpes, Genital hygiene, acyclovir 200 milligram orally, 5 times daily for 7 days. Treat partner and promote condom. If the genital ulcer are present, may have swollen groin lymph nodes. If it is yes, then we give benzathine penicillin 24 lakhs IM after test dose with tablet ciprofloxacin 500 milligram statum. It is contraindicated in pregnant women, or capsule doxycycline 100 milligram BID for 14 days, contraindicated in pregnant and lactating women, and tablet erythromycin. We should prefer steroid rather than estrelate. 500 milligram QED for 14 days in pregnant women also. Treat the partner and promote condom. This is the flow chart. Same way, we have a flow chart for urethral discharge. We have a flow chart for vaginal discharge. We have a flow vaginal discharge where speculum is used. We have a flow chart for lower abdominal pain and for inguinal PIBO, painful scrotal swelling, or neonatal conjunctivitis. You can easily download from NACO website or CDC, Center for Disease Control, these flow charts and have it in your clinics or hospitals. I will make it still simpler. I'm going to tell about 7 wonders of sexually transmitted disease. These are pyramids which are there in the hot desert. We have to travel in the camel for a long distance. And even after nearing the pyramid, many of us may not like to enter into pyramids because of the mummies or the dead bodies which are being preserved. And we may feel that evil spirits may be there. So many people will not enter into the pyramid. Just like that, if a sexually transmitted disease patient comes with genital ulcer, or receive him like any other patient, listen to him, whether he had extramarital exposure, unprotected sex, and just have an aerial look, just like seeing the pyramids aerially, and treat him with syndromic management. This is the Eiffel Tower, which I have put for genital ulcer, non-herpetic. Genital ulcer, if it is single or multiple, painful or painless, burning sensation in the genital area, enlarged lymph nodes, we give benzathine penicillin 24 lakhs, azithromycin 1 gram single dose. So this comes as a kit supplied freely by NACO to all government hospitals and to certain designated private hospitals. If he is allergic to penicillin, we use doxycycline 100 milligram and azithrom for BD for 15 days, azithromycin 1 gram single dose. This is for non-herpetic genital ulcer. If it is a herpetic ulcers, genital ulcers are vesicle, single or multiple, painful, recurrent, burning sensation in the genital area, we use acyclovir 400 milligram TDS for 7 days. Actually, I told you 200 milligram previously. For herpes zoster, we use 800 milligram of acyclovir. In the syndromic approach, we use 400 milligram TDS for 7 days. This is the slanting tower of Pisa. We have used it for urethral discharge because of the constant irritation in the urethra. The penis will be almost erect, partially erect, and it may not have full erection like. So I have used this slanting pyramid. Slanting tower of Pisa. Urethral discharge, pus or mucopurulent, pain or burning while passing urine, increased frequency of urination, systemic symptoms like malaise, fever. Here we use azithromycin 1 gram to treat chlamydia, tablet suffixing 400 milligram OD stat to treat Neisseria gonorrhea. So this comes as a kit, 2 tablet, 1 azithromycin 1 gram and suffixing 4 milligram. If there is a vaginal discharge, I have used Taj Mahal. It is not white, pure white now. It is about dirty white or yellowish white now. And it is discharge also in a woman looks yellowish white. Natural and type of discharge, quantity, color, and odor, burning while passing urine, and increased frequency, genital complaints by sex partners, low backache. Here we use technidazole 2 grams OD stat and fluconazole 150 milligram OD stat. So it will take care of trichomonas vaginalis, bacterial vaginosis, and candida in vagina, vulvovagina. So if the discharge only from the vagina, if. Otherwise we have to use a speculum and see that this discharge does not come from the cervix or ectocervix. If the patient has, apart from genital discharge, lower abdominal pain, it shows that this is a pelvic inflammatory infection, PID, pelvic inflammatory disease. Here the patient will have lower abdominal pain, fever, vaginal discharge, menstrual irregularities like heavy irregular vaginal bleeding, dysmenorrhea, dyspareunia, dysuria, and tenesmus, low backache, cervical motion, tenderness. If we introduce the finger into the gloved finger into the by doing PV and move the cervix sideways, the patient will have severe pain. This is called cervical motion tenderness. For this, we use cefixime 400 milligram OD stat, metronidazole 400 milligram BD for 14 days, doxycycline 100 milligram BD for 14 days. Cefixime will take care of gonorrhea. Metronidazole and doxy will take care of chlamydia and anaerobic organisms. So I have given the Statue of Liberty. If the woman has multiple sex partners, and probably they will land up in PID. This is the Great Wall of China. For me, it looks like inguinal ligament from anterior superior iliac spine to symphysis pubis, and the lymph nodes above and below the inguinal ligament may be involved. Inguinal swelling in the inguinal region, which may be painful, preceding history of genital ulcer or discharge, systemic symptoms like malaise, fever, etc. Here we use azithromycin 1 gram and doxycycline 100 milligram BD. Azithromycin is for venereal granuloma, and doxycycline, even if it is a syphilitic pubo, it will heal. This is the hanging garden of Babylon. In male, there is a hanging garden called scrotum. Just like pelvic inflammatory disease, the epididymoarthritis can occur. And so I have used this hanging garden of Babylon. Swelling and pain in the scrotal region, pain and burning while passing urine, systemic symptoms like malaise, fever, history of urethral discharge. Here we use azithromycin 1 gram to take care of chlamydia, cefixime 400 milligram statum to take care of gonorrhea. And we also have enhanced syndromic management. In a hospital setup, if you have existing guidelines of STI management, plus facility for basic on-site laboratory support, then we can use this enhanced syndromic management. We have to take a detailed history, thorough physical examination, including speculum and proctoscope, complementary laboratory procedures, and quality STI management. We have full etiological diagnosis may not be possible. Gonorrhea and chlamydia, especially gonorrhea and chlamydia, no affordable rapid diagnostic or screening test. All women treated with presumptive for cervicitis on their first visit, subsequent visit risk assessment by history examination and laboratory findings, high risk for possible reinfection, and clinical evidence of cervicitis. In the on-site, we use gram stain, KOH, potassium hydroxide, vaginal pH, rapid plasma reagent, and TPHA. So advantage is no need for multiple treatment, use of expensive drugs minimized, no repeat treatment for candidiasis or cervicitis, once a month checkup. So the laboratory support is etiological diagnosis of candidiasis, bacterial vaginosis, and trichomoniasis can be done by wet film and KOH sting. Causes of cervicitis, gonococci observed in gram stain. RPR offered to all women every month. Women treated every 3 months. Women treated on positive RPR should not wait for TPH result. All slides and syrup preserved for quality control, even asymptomatic women to be screened. Then we have treatment of partner. We call primary contact the contact from whom the patient has got the infection. Mostly the males get the infection from commercial sex worker or some known extramarital contact. And secondary contact is those contacts to whom he has spread the infection, maybe the innocent wife. And we give what is called epidose, epidemiological treatment. Short term for epidemiological treatment is epidose. Epidose is always full dose, same as treating the patient with sexually transmitted disease. So I told you 10% of the patient, 10% of the patients, they have HIV. So when HIV in general, common disease not responding to routine line of management. This is scabies. We call it as Norwegian or scabies, which is easily treated with permethrin or gamma benzene hexachloride or benzyl benzoate. But these patient with HIV patient with scabies will not respond to routine line of management. So we have to, so common diseases not responding to accepted line of management, we have to suspect HIV. This is molluscum contagion. This is herpes, multidermatomal herpes zoster. Unusual presentation of common disease. You know, molluscum contagioso occur in children. Here, the adults are involved with molluscum contagioso. You know, herpes zoster is on the one side on a single dermatome. Here in HIV, it will be multi-dermatome. This is the infection which many of us would not have seen. This is Kaposi's sarcoma. Uncommon illness in uncommon individuals, we should suspect HIV. The mouth, apart from caries tooth, he has got gingivitis, after ulcer, oral hairy leukoplakia. Here in the lung, he has got, apart from tuberculosis, PCP, pneumonia is there. More than one disease in a single organ, we should suspect HIV. This is candidates of the candidates of the hot palate, soft palate, candidates of the esophagus. So single disease occurring in more than one organ, we should suspect HIV. Pulmonary tuberculosis abdomen, tuberculosis meningitis, pericarditis in the skin, we should suspect HIV. So STD patients, if we apart from treating, we have to educate them. We should tell, especially to the youth. A is for abstinence. Friendship should not cross the boundaries at any times. They can move with each other, be friends, but not go up to the things of sexual intercourse. This is B, advice for the husband and wife, spouse, faithful to the partner. Marital relationship should be mutual, trusted, and long-lasting. This is for people who will not listen to A and B, abstinence or being faithful to partners. Here we tell them about C, that is the condom. Never condom condom. If you have premarital or extramarital contact, always use condom. It is not that we are promoting condom, but we are cautioning them if they cannot control them. Any individual indulging in indiscriminate, unprotected sex will eventually end only in misery. Those, they may think it's a pleasure to have extramarital, premarital contact, but at the end of the day, they will be having sexually transmitted diseases, HIV, or social diverse, like that. So many problems they will have. Any country ignoring HIV or STD is only behaving childish and virtually land up in severe political, social, and economic medical disaster. And India being a pious country, we should not think all people will be pious and everyone will maintain this chastity. We do have commercial sex workers in many of the metropolitan, and we have extramarital contact, people working in the office or working elsewhere together. So Abdul Kalam is a great motivator for all the youths. He is a role model. Even though he does not say about STI or HIV, he cautions them on their duty to have a vision, to have a goal, and achieve the thing without any deviation. Deviation itself includes these things, like marital contact, extramarital contact, premarital contact, and all. So every child is a good child when it is born. Only when, whether it in other things, it all depends on the factor, so many social factors. Just say no to female feticide. Females are very important to these things, and the medical community should not be a part of this female feticide by doing the ultrasound and revealing the sex of the child, or doing a medical termination of pregnancy in the first trimester, that 2 second or things. So,
Hello.
yeah.
Yeah, sir. There are also some questions are there. I will just post the questions one by one in the chat.
What is the question?
Stop sharing screen.
Stop sharing. Is it visible now?
Yes, sir.
Tell me the questions.
Yes.
is there means of generalizing antibiotics that will completely eradicate the bacterial infections? See, bacterial resistance or drug resistance takes place. We have to keep on inventing new drugs, things, especially for bacterial infection. But we do not have a Treponema pallidum, which causes syphilis. So penicillin is still effective. There is no penicillin resistant Treponema pallidum. But we do have Neisseria gonorrhea. When sulfadiazine was just introduced, 2 tablets of sulfadiazine was sufficient. So then Septron or Bactrim, cotrimoxazole was effective. Then amoxicillin was effective. We increased the dose up to 3.5 grams. So many drugs, Neisseria gonorrhea has become resistant. That is why now we use the drug cefixime. So usually 400 milligram, usually we use 200 milligram. So no 400 milligram should be used for other infections. It should be reserved only for this STI or gonorrhea. So we have what is called chlamydial infection. So a single drug is not there to control both gonococcal and chlamydia. Same way, aerobic, anaerobic organisms are there. There is no single drug. We have to use a combination of drugs, like ciprofloxacin with tinidazole, norfloxacin with tinidazole, like that, ofloxacin with secnidazole. So we may have to use a combined drug rather than a single drug for bacterial infections. So, but we are using only a few drugs. See, azithromycin, cefixime, metronidazole or secnidazole, doxycycline or erythromycin, and fluconazole. So these only 5 or 6 drugs are being used here. Thank you. Is there any other question?
Yes, sir. The second question has been posted in the chat.
I am not able to see.
The question is, does pregnancy place women at the increased risk of becoming infected with HIV?
Yeah. See, the HIV virus is not a motile virus. It cannot penetrate into intact skin, but sometimes they get into mucous membrane. That too, if it is abraded. Abrasions are there, it can enter. And this HIV requires a target cell called CD4 cells. And it is very much available both in female and male genitalia. Just under surface of the prepuce, we have Langhans cells, and the inner surface of the prepuce gets traumatized during to and fro movement of the penis within the vagina. So the abrasion is there, target cell is there. So this HIV virus gets easily into the people, and that is why in Africa, the HIV was not that much present in Muslim population than Christian population. This is because Muslim population, they undergo circumcision before puberty. So these people had less chance. It is not that 100% proof, but so the Christians also in Africa, they had their children circumcised to prevent their children from getting the HIV. So this is for getting the infection. Then, when an ulcer is there in a HIV positive patient, these CD4 are called helper cells. They help in the healing or overcoming the organism. They engulf the causative organisms like a macrophage and they destroy these things. So in ulcer, these CD4 helper cells are pulled together, and along with healthy CD4 cells, the HIV infected CD4 cells also are also pulled into the ulcer site, and they burst. Usually they burst, and these HIV virions are being liberated. So the discharge, serous or purulent, or this one, discharge, sanguineous discharge, contain lot of Treponema pallidum because of this bursting of infected CD4 cells, and they infect the partner. So that is why it is there. And in the saliva, HIV concentration is not that much. So during kissing, the chances are very, very remote. If not, it is not there at all. But the seminal fluid and the vaginal fluids, they contain Treponema pallidum. Like any other macrophage infected things, they come and become burst, and they have this. So that is why seminal fluid, this one, vaginal fluid and blood are very, they are infective because they do have these HIV variants in them, and they can infect. This is sufficient. I will take it elaborately when I deal with HIV per se in some time later.
The third question is there. Who is more at the risk of becoming infected with an STI, men or women?
Definitely it is the women. Because for men to get the infection, it is like climbing the Everest. The virus has to, from the this one vaginal fluid or the things, the virus has to cling on to penis, get under surface of the prepuce, go there, and it is like climbing the Everest. In women, it is like a Ganga flowing right from the mountains. The virus particles are showered into the vagina from in the seminal fluid. So they are at more risk. Women, the chance of infection is double than the men.
So the last question is, what are the risk factors of piriformis syndrome?
What syndrome?
What are the risk factors of piriformis syndrome?
Can you send it through the chat box? I'm not able to. Or can you spell the syndrome?
Yeah, it is PIRIFORMIS. Piriformis syndrome.
Sorry, I don't get you. Perhaps we in a sexually transmitted disease we have what Reiter's syndrome. Reiter's syndrome is urethritis, conjunctivitis, arthritis we have, and we have Hicks-Curtis syndrome. That is pelvic inflammatory disease going on to liver and involve the outer layer of the outer cover of the liver. Hicks-Curtis syndrome we have, and the rest of the syndromes I am not. Anyway, please post it in the chat to my WhatsApp so that I'll give the things, and I'll let me know. I'm not able to get the entire thing.
Okay, sir. Sir, we are done with all the questions. Yeah, and thank you very much, sir, for your valuable time, sir.